Hi, this is Brandy from Mana Health Partners, bringing you another video from our educational series, this time on definitions and audits. So our objectives today are to review definitions and what they really mean. Stable condition is the condition, not the patient. Chronic illness is the condition, not the patient. And also we're going to review audits done by not only myself, but billing specialists, and why the rationalization of these audits are so important. So when we're going through definitions and discussions. So a physician is or other healthcare professionals are somebody that are working under their scope of practice or licensure that are not working directly under our supervision. So that would be when we collaborate with other people, that would be the wound physician. They're not working under us, the director of nursing, any licensed nursing staff. They're not working under the supervision of the physician or a healthcare professional. They're not working underneath us. Next thing, a problem. A problem is a disease, condition, illness, injury, symptom, sign, finding, complaint, or other matter addressed at the encounter with or without a diagnosis being established at the time of the encounter. So notation in a patient's medical record that another professional is managing the problem without additional assessment or care coordination does not qualify as being addressed by the provider. So if you've got weakness and they're being followed by physical therapy and we're not doing anything to intervene medically for them, we do not get to utilize that as a problem. We don't count weakness as a problem. Now, we absolutely put it under the history of present illness. They continue on therapy to get stronger, but under assessment and plan, we have no plan. Therapy has a plan, but we are not treating them. A minimal problem is a problem that may or may not require us to do an assessment. So they might call and say someone has a cough, and over the phone you can give them an order for Robitussin. Self-limiting or minor, meaning that it can resolve on its own, it's transient in course, and it's not likely to affect their health status. Now, stable chronic illness. I want to emphasize the word illness. This is not the patient. This is the condition. They have a chronic illness. This is a problem with an expected duration of at least 1 year or until death. So it's a chronic illness. They're going to live with it for the rest of their life. And then it's based on the stage or severity. So stable is defined by the specific treatment goals for the patient. A patient who is not at his or her treatment goal is not stable if it has not changed and there's no short-term threat or life of function. For example, a patient with persistently poorly controlled blood pressure for whom better control is a goal is not stable. Even if the pressures are not changing and the patient is asymptomatic. Again, we're not talking about the patient. We're talking about the chronic illness. So if the patient is asymptomatic, but their condition is stable, the risk of morbidity without treatment is significant, they would have a stable chronic illness. On the other hand, acute uncomplicated illness or injury is a recent or new short-term problem. It's not a chronic condition. They're not expected to have it for the rest of their life. So you've got low risk of morbidity. There's little or no risk for mortality. They're not going to die from it. It's uncomplicated. It's just a simple thing. Stable acute illness means that there's something new or recent for which treatment has been initiated. The patient is improved, and while resolution is not complete, it's stable. So that could be a UTI. It's an acute illness, and it's not complete, but they're stable. They're on antibiotic therapy. Chronic illness with exacerbation, progression, or side effects. Now, you'll notice that's familiar from medical decision making. Is a chronic illness that is acutely worsening. So that could be congestive heart failure with increasing shortness of breath and decreased O2 sats, or poorly controlled, a chronic illness that's poorly controlled. That could be diabetes with an A1C of 9, or not stable or progressing. So a chronic kidney disease, stage 3, their GFR was 46, now it's 41, and then the last time you took it, now it's 30. So it's progressing. And so is that a big deal? Yes, it's a chronic illness and it is progressing. Or if they have side effects from treatment. So that could be hypertension, which would be a chronic illness, and they would have side effects. They're on lisinopril and they've developed the lisinopril cough. Undiagnosed new problems, you can read on that yourself. I'm just going to highlight some of the bigger issues. Acute illness with systemic symptoms and acute complicated injury. Let's focus on that one for a second. It's an injury that requires treatment in evaluation of body symptoms that are not directly part of the injured organ. So let's say you have diabetes and you're on insulin. So now you've got kidney issues, which is directly related to diabetes, or you've got hypertension that could be related, or the hypertension could be causing your kidney issues. So it's a complicated issue that's going on. So let's say your GFR continues to decline and it's extensive. What are our treatment options? You're going to go into kidney failure. And then when your GFR hits 15, you need dialysis. So these are complicated issues that are affecting an organ that could potentially cause morbidity and mortality. A chronic illness with severe exacerbation, progression, or side effects. So there's a chronic illness that is having a severe exacerbation, that's CHF, that's 4+ edema, that's 2+ JVD, that's shortness of breath on laying down and with sitting up, and it's on O2 with O2 sats at 91. So that would be a chronic illness with severe exacerbation. An acute or chronic illness that poses a threat to life or bodily function. I go back to chronic kidney disease, and as we're declining from 30 to 18 to 15, and maybe cardiorenal issues, so you can't diurese them anymore because the kidneys are going bad, you've got CHF and 4+ pitting edema. How do you negotiate that? So the patient may be stable. They may complain that their feet are swollen. Maybe they're not having an exacerbation of shortness of breath, but their condition is absolutely not stable at this point. So remember, we're talking about condition, not the patient. The patient may feel great with a GFR of 30. That doesn't mean the patient is not stable. It means the condition isn't stable. So a discussion. So this is anything that we're talking about. It doesn't have to be on the date of encounter, but you've counted only once. So if you've had a discussion with a family, you don't get to write that every single time. You only use it once. And so if you're doing your documentation and you've done all of your documentation and you've placed a call to the family and the family calls you back the next day, that counts as discussion with the family. An independent historian, that could be anyone who provides history. If your patient is confused, has dementia, and the family's at the bedside saying they look like they're in pain, or they told me they're having pain, anything like that. Independent interpretation. So it's an interpretation of a test, which there's a CPT code for, and that test is customary. So it doesn't apply when the physician or other provider reports the evaluation management service is reporting or had previously reported the test. So you only get to count this as once as well. And the interpretation should be documented but not conform to the usual standards of a complete report. So, for example, I went to my ortho. He did not have the results of my MRI, but he did have the scans, all 96 scans. And as he was scanning through, he saw that I had some bursitis in my shoulder. He didn't measure it. It wasn't described to him. So he interpreted that based on the frames that he had, the 96 frames. And so he interpreted that before he got the official interpretation from radiology. It would be the same thing as if you were getting an ultrasound for one of your patients, you were standing over their shoulder and you could see that there's a blood clot. You ask them that looked like a DVT. Some of them will say yes, some of them will say, I don't know, I'll have to have the radiologist get back to you. But it's you interpreting that we're not going to wait 6 hours before we interpret that we could clearly see there was a blood clot there. Appropriate source, this would be somebody that is a professional, but not a healthcare professional. So that could be a lawyer or a police officer, a teacher. It doesn't include any staff that we're working with. Again, those would be healthcare providers, nor would it include any kind of family, friends, etc. So appropriate source would be a professional, but not a healthcare professional. I will attach this so that you can review all of those other definitions, and you can go through them more thoroughly. But I did want to make clear that what we're talking about here is the medical condition or diagnosis and not the condition of the patient. We're talking about the condition of the diagnosis. So let's jump right into audits. You're probably getting this video or getting a reminder of this video because we've done an audit. And so this is the reasons why we do audits. So first of all, you should expect regular audits from myself and the billing specialist as well as corporate compliance once we get that in place. We do have the billing specialists. They're people that have their masters and they specialize in coding and billing. So these guys are professionals. Chart audits are a critical component of insurance and billing process, not only to help maintain the accuracy, compliance, and integrity, but to make sure that you're getting the feedback you need to make sure that your notes are meeting criteria. They contribute to financial stability. If your notes haven't met criteria for 1 year and you haven't been audited and you don't know that and you continue to document, they may end up taking money back on all of your notes. So we have to make sure that we're all in compliance. And it also helps prevent fraud or and also ensure quality patient care. So if you're billing all of your charts at a 99310 and your HPI says patient laying in bed, no complaints of pain, and stable, that really doesn't meet the criteria. And so that really is fraud. You're overbilling. And not only overbilling is fraud, but underbilling, undercoding. So we want to make sure that we know how to code and that we're doing it the right way. So a chart audit is a review of the patient's medical record against your documentation to make sure that your note is reflective of what the patient's condition is and what's going on. So I always like to go through the easier things and say, if a patient is obese and you missed obesity, what else did you miss in your note that I didn't get to evaluate during that time period that maybe a family member or a friend has seen and we haven't documented? So for billing accuracy, chart audits help to make sure that we are fitting compliance with the insurance company. So that's Medicare, that's Medicaid, as well as all of the other insurance companies. So we want to make sure that what we saw with the patient is actually documented, and what is documented is actually billed appropriately. We want to make sure that we're in compliance with coding guidelines. So insurance companies use specific coding such as ICD-10s and CPTs. So the CPTs are what tell us how much money we're going to make for that visit, and the ICD-10s are what support that. So if we're asking for a higher amount of money or reimbursement for what we've done, we have to prove that we've earned that, or the patient is sick enough and our documentation reflects that, to get that reimbursement in. It helps with compliance. Insurance companies deny claims if the documentation doesn't meet certain criteria. So what are those criteria? Well, in another video, we've talked about what an HPI should reflect in our new hire orientation, for billing, for documentation standards. So we do chart audits to make sure that if we identify any deficiencies in documentation, that we notify you and that we can correct them. Fraud prevention, chart audits are an essential tool in detecting and preventing fraudulent activities. For risk management, that we're actually documenting stuff like wounds and weights and falls to make sure that if there's a risk management issue, we are documenting that, as well as making sure if the patient is non-compliant with turning and repositioning and diet changes and they have a wound, it is likely that they may not get better, and that's not on us. So we need to make sure that areas of non-compliance are documented. And then quality of care, while not directly related to billing, chart audits can also assess the quality of healthcare provided. If we say the patient has a wound and they're getting better, where is that as far as how do we verify that they're getting better? Well, they're being followed by the wound team. They're getting measured. The wound team reports that the wound is getting better. Wound on the left buttocks has no signs and symptoms of infection. The dressing is clean, dry, and intact without drainage. So what we want to do is make sure that we're providing that quality of care. We want to make sure that we're standing within the regulatory framework, not only JACO, but ACA, not only the state surveyors, but the federal surveyors should they come in. So we want to make sure that we're following specific standards. And then reimbursement optimization. If you're not billing based on what your note reflects, we're not billing right, whether we're upcoding or downcoding. We need to make sure that we meet the criteria for reimbursement. And so if we are seeing the patient for a longer amount of time, or we are spending time with the family for a longer amount of time, we optimize our billing to make sure that we're getting the maximum amount of reimbursement that we can. If you found this video helpful, please let me know. If you have any questions, my email is down at the bottom. My phone number is attached right here. Please reach out, let me know. And then if there's anything that I can do to help you, if you have any questions, if you have any feedback, if you're getting audited and you don't understand the results of some of the audits, let me know and we can go from there. But I definitely want to be able to work with you, help you, and grow your documentation so that we meet those criteria for the audits. And I help you understand a little bit better with my explanation on conditions, chronic illnesses. So until next time, I'll say thank you for participating and have a great day.